we will be receiving Dr. Chang-Woo CHOO from Seoul Maria Fertility Hospital. He has been the chief of Fertility Preservation Center in Maria Fertility Hospital in Seoul. He is part of the academic committee in the Korean Society for Reproductive Medicine, the KSRM, and the Korean Society for Assisted Reproduction, the ASAR. He's also a member of the Korean Society for Fertility and Presentation. So let's welcome the General Affairs Director of the Korean Society for Reproductive Immunology as well, Dr. Chang-Woo CHOO. Are you with us, Doctor?
Okay, can you hear me now?
Yes, perfectly.
Thank you, Casanori. I am Dr. Chu from Seoul Maria Fertility Hospital. And first of all, I very appreciate you, Igenomix APAC and Igenomix Korea, for giving me this good chance to talk about ERA and the personal and Korean experience sharing case. And from now, I'll show you my slides. Yeah, I'm from Seoul Maria Fertility Hospital, and Seoul Maria Fertility Hospital is headquarters of Maria Fertility Group, which contains 10 domestic and 2 North American branches, and performs over 15,000 to 20,000 fresh IVF cycles annually, and it contains over 40%, about 40% of all Korean domestic fresh IVF cycles. First part is about statistics, and by global data until 2020, over 125 samples were biopsied, and in them, 37.4% was non-receptive, and vast majority, 30% is pre-receptive. It is performed over 9 countries, and it contains more than 4,000 clinics, and 90% of cases only needs 1 biopsy. Considering APAC area, until 2021, over 20,000 samples were obtained, and among them, 40% was non-receptive, and as we've seen before, 25% was pre-receptive, and 3.9% was post-receptive. APAC contains 12 countries, and more than 500 clinics were included. Checking for South Korea, we have only very limited cases of explained because there's some legal and governmental issues. Because I'll tell you about them later. And total about 500 cases were examined, and among them, 43% was receptive, and including early and late receptive cases, 72% was receptive, and it fits the global and APAC data, and 21% was pre-receptive, and 6.6% was post-receptive. We distributed it by age, and for younger women with 30 to 34 years old, receptive data was 47%, and pre and early receptive data. Early receptive means about 20 hours of shifting of windows of implantation. It contains 42%, and late receptive and post-receptive accounts for about 10%. For more elderly women with 35 to 39 years old, receptive data was 46%, and pre and early receptive was 33%, and late and post-receptive was 20%. And checking for more elderly women with over 40 or over years old, receptive result declines to 38%, and pre and early receptive increased to about 40%, and post and late receptive increased to 21%. We divided it by checking the number of previous failed implantation, and if the failed implantation number was under 3 or under times, the normal data was 43%. But if the previous failed implantation number grows to 4 to 6, the normal range was 49%, and it overs 7 or more times, the normal range decreased to 33%, and pre or early receptive result was around 40%. Because this data shows 1 to 3 failed implantation shows less receptive result, but because this result might derived from because this number of patients is not that much, because vast majority of patients was 4 to 6 times of previous failed cycle, and the next is over 7 or more cycles. So we can add this result by checking previous failed implantation cycle of 6 times or under and 7 times or more. We can see the result by the receptive result as 47% versus 33%. And this means women who experienced too many times of previous implantation failure has the chance of shifted, the displaced windows of implantation. This means if there's no other specific finding or corrected other workup, we should consider about the displacement of windows of implantation if there's uninterpretable or unanswered implantation failure occurs repeatedly. From now, I can show you my data. This is Seoul Maria Fertility Hospital. It locates the north side of Hangang River and near the center of the Seoul city. I have somewhat different personal indication for ERA test. It contains there's no endometrial pathology or corrected pathology, and always moderate to good quality embryos were transferred before, and 3 or more times of failed embryo transfer cycle in spite of corrected recurrent implantation failure workup result. It contains immunologic factor and thromboembolic factor and chromosomal factor or other anatomical factor or infection. And if the patient has 3 or more times of failed embryo transfer cycle after PGT-A, that means chromosomally normal, genetically normal embryo was transferred 3 or times more. And every patient get informed consent. So we can interpret total 47 patients result, and it shows only 29% of receptive result, and adding pre-receptive and early receptive case, about 60% of result was displaced windows of implantation, and post-receptive and late receptive contains about 10%. This is very low percentage for receptive cases. It is divided by the age, and as you've seen before, because from 30 to 34 years old, patient number is very small, it cannot be interpreted statistically. The receptive case was 33%, and pre-receptive was 60%, and late and post-receptive was 6.7%. For women with 35 to 39 years old, receptive was 46%, and pre and early receptive was 46%, and late and post-receptive was 6.7%. And interestingly, For women with 40 or elder women, receptive result was only 11%, and pre and early receptive cases was about 70%, and post or late receptive was about 18%. This means women with old age has the tendency to have displaced windows of implantation, and it can arise from her age or other medical or general health condition expected. And we divided it by the distribution of number of previous failed implantation, because my personal education has at least 3 or more times of failed ET case required, so there was no 1 to 3 time cases was involved. So if the patient has 4 to 6 times of previous failed implantation rate, the normal ERA test result, receptive result was 35%, and pre and early receptive was over 50%, and post and late result was about 12%. And for the patient which experienced 7 or more times of previous implantation failure, the receptive result was only 19%. It's very low chance. And her pre or early receptive result was around 70%, and post receptive result was 9%. The next slide is about people and further advancement. The first part is ERA and Emma and Alice. Because today's presentation has many sessions for Emma and Alice, so I only will show you about the test only, but not precisely. Yeah. Generally, we use HRT routine protocol for using estradiol tablet or patch, and check the ultrasound and blood serum progesterone level, and we use progesterone vaginal suppository or injection, and we use biopsy about 5 days later. Then the ERA test shows the timing was receptive time in the middle of windows of implantation or displaced, and we can check the result, and next time we can adjust the embryo transfer date, and it is called as personalized ET, or if the displacement is 2 days or more, generally second biopsy is suggested. And so after correcting the displacement, another ERA test is required, and if the test result is receptive, we generally recommend patient will personalize the embryo transfer. But there's another studies too. The first is about microbiome, because endometrium is generally lactobacillus major. The majority of microbiome is lactobacillus. So if the microbial composition is shifted, it can be harmful for embryo to implant and grows well. So this study is MR, and if there's evidence of chronic endometritis, you can use the study of Alice. So they recommended decision tree like this. If the MR test or Alice test has some problem, you can correct it. If some dysbiosis or other kinds of problem, we can use some prebiotics and probiotics to check the normal flora. And if there's some evidence for endometrial chronic endometritis, we can use antibiotics, as you've seen before, and we can check the endometrial condition again. But there's some argument until now, and this is one of the very popular argument about ERA test, because some scientists and practitioners have some debate about this test because it is an unproven technology, and they argue can be classified as like because there can be some inconsistency of endometrial biopsy, and because the biopsy cannot explain the embryonal induced effect, the embryo-induced change, embryo-induced endometrial change is abandoned, they said. And another people is the failure to account for the simultaneous serum progesterone level, and the expected low percentage of patients requires this test, and there's only around 30% of abnormal receptivity test. And there's some difficulty in synchronization in endometrium bio HRT cycle or natural cycle. And because ERA test requires embryo frozen embryo transfer, so there can be expected perinatal risk associated with routine cryopreservation. And there's no gold standard to compare. And another claim is the windows of implantation might be up by only 12 hours, very short time, because this short time of change can make some big result like pregnancy and non-pregnancy, and it can be questionable. And there can be intra-patient variations too. So there's some more and more experiences required, and data should be collected. But because already this ERA test has over 10 years of experience, and so the data is getting more precise and adequate and reliable. And this is interesting case report because in North America, there's two commercially available endometrial receptivity array. One is ERA test and another is additional RT test. And a clinic in Canada performed these two testing for one patient, and ERA data suggested this receptivity on day 5 of progesterone treatment, but additional result was receptive on the 8th day. There's some different result on two exam. So they performed another biopsy test on 8th day of progesterone treatment again, and the result shows that the ERA shows post-receptive, but additional shows there it was a receptive time for endometrium to implant. So the author concluded that the interest validity studies are recommended. So until now, there's no gold standard about the endometrial gene expression pattern, and by the test, which expression pattern is applied by the test, we can get on a different result of the test. So the explaining the test result and applying it should be depends on the clinician, and it should have enough discussion with patient, and another more and more studies are required. My next step is about recent advancement, and this paper is from Japan, and this shows chronic endometritis can shift the windows of implantation. This study checked by CD138 positive plasma cells as a marker of chronic endometritis in endometrial biopsy. And for patients without chronic endometritis, the ERA test was non-receptive was 42% and receptive was 47%. But for endometritis group, the receptive was only 15% and non-receptive was 84%. And if the chronic endometritis is cured, another ERA test result was receptive was 15% and non-receptive is 50%. And this is statistically not different from non-chronic endometritis group. This means chronic endometritis can make windows of implantation for non-receptive. And if the chronic endometritis is cured, the windows of implantation shifting can be reserved. And this table is from the study 2. And for non-chronic endometritis groups, if the windows of implantation was corrected by ERA test, that is so-called personalized ET, the clinical pregnancy rate was 77%. But comparing that, for chronic endometritis group, after personalized ET, pregnancy rate is only 22%. And if the chronic endometritis is cured, the pregnancy rate is 51%. And for cumulative ongoing pregnancy rate after 2 consecutive embryo transfer, the pregnancy rate for non-chronic endometritis group is 85%, and for chronic endometritis group, it's only 30%. And if it is cured, it rises to 78%, and this is very similar to non-chronic endometritis patients. My last slide is about Korean situation. Yeah. And Korea has national health insurance system, and it is obligation for all domestic people. So over 99% patient population is involved in national health insurance system. And this system was applied to ART field from 2017. And so for all insurance subscribers, 70% of all costs are covered by insurance. Only 30% is paid by individuals. And for out-of-coverage items, it is 100% paid by people. And because Korea suffers population crisis with world lowest birth rate, so we have another additional support system. This can be simultaneously applied to patients with the national health system. This additional support system is depend on household income, and for fresh cycle IVF, approximately $1,600 is given to the patient. And for frozen cycle, for one frozen cycle, about $800 is supplied by government to the patient. And about 70% of patients was covered by this additional support. So Korean patient has two different reward. One from national insurance system, about 70% of our cost, and another about over $1,600 per one IVF cycle. So individual pays a very small amount of money for IVF. And Korean national insurance system and law strictly restrict off-label usage of medicine, and it can be, in some cases, it can be punished. So there's some problem for us to widely apply ERA test to our patient. The first is financial support system. That is to say, because patient pays a very small amount of money only for IVF cycle. So if another ERA test is suggested, it can be very burdensome for the patient because he or she pays a very small, only very small money, but because this test is out of coverage item, the 100% is paid by him or herself. And the second is about prohibition of off-label usage of medicine or test. And there can be some legal restriction and punishment. So every practicing doctors have some worry and anxiety for suggesting this new kinds of test or drugs for the patient. So if Igenomix Korea and Igenomix APAC and worldwide has some more try to make this test into the NIH, the National Health System, insurance system, or at least the legal area, there can be some much more wide ways for this clinician like us to use this kind of good test of ERA or EMMA or ELIS. This is my last slide. Thank you for listening. Thank you.
Thank you, Dr. Choo, for your presentation today. We have a few questions from the audience. The first one is from one of the people watching from China, and this person asked, according to the ratio of ERA in the standard population and the non-standard population, is there a situation that the ERA tolerance period is getting later with the increase of age?
It depends on the character of patient population. And in my case, I show my data shows the age grows older, even like or 40 years or older, the normal receptive ERA test result population was decreased. And this might be there's some other that is to say like chronic endometritis or other hormonal or anatomical like endometriosis or fibroid can make some change for the patient endometrial situation. So there should be some more data should be collected and more studies should be done, but there could be some chance for patients' age and other medical general health condition or medical condition can change the window of implantation. So last time I showed the Japanese study journal, and the author says that because chronic endometritis can influence the window of implantation displacement. So before checking the ERA test, chronic endometritis should be checked and if needed, it should be cured. So because it can change the window of implantation. And it will be the answer, I guess.
I see. Thank you very much. Following this question, I see here we have a related topic question, so I will ask this one first. We have a question which arrived, and it's like this. What kind of patient would you suggest to do the ERA based on your research? Advanced staged women are more preferable?
In my personal experience, because there's some legal problem in Korea, I generally do not suggest ERA test earlier. If other RIF workup was tested and corrected and PGTA was done and hysteroscopy or other kinds of workup and treatment, for my guess, everything was done, but there's no pregnant. At that time, generally, I suggest to the patient about the ERA test. And so it does not depend on the age of the patient, but the expected chance for the patient's pregnancy rate. That means if her every workup result was good or can be easily corrected, and her embryo is good, and her womb, endometrium is good, everything is okay, but there's no pregnancy. At that time, I recommend it generally. Thank you.
Okay, thank you for your explanation. Do you have time for one more? Okay, So we have more questions. Unfortunately, we don't have time for all of them. So I will ask you our last question of the day. So here is it. Do we have the ERA test result of general population or fertile controls? What is the difference of ERA result in fertile controls versus pregnant group after 1-2 times of embryo transfer versus women with over 3 times implantation failure?
Okay, this is very good question, I guess. And I think this question is not for me, but for Igenomix. And because today's last session is from Igenomix Spain, you can get some answer about the precise answer from her. But generally, for my knowledge, for there's some displacement on control, the percentile control groups of women, but there's some chance difference. Good percentage is different from RI patient, I guess, but it is not enough for explanation. And another precise explanation is required by next session, I guess.
Yes, perfect. Actually, this person sent 2 questions together. And the second question is, according to your data, is it more reasonable to apply ERA in women with over 7 times implantation failure or in women over 40 years old with over 3 times failures?
That is exactly what I want to speak today. Yeah. For my data, if another RIF workup is performed and enough trial is done, ERA can be considered and applied, and in that case, there can be increased chance for displaced window of implantation, I guess. So I generally do not request suggest patient the ERA test earlier, but if after any kind of test and treatment is applied after all, but even then there's no pregnancy, successful pregnancy, the next step can be ERA, and practically I use ERA test in that way. Thank you.
Thank you, Dr. Tu. We will close the questions for now. We have more, but they will be asked later. And this was the experience from Dr. Tu, straight from Seoul, South Korea. Thank you so much for joining us.
Thank you.